As today's topic, intervention and treatment, and we're going to talk a little bit about how to work with individuals who are alcohol affected. I do want to note that I'm a Department of Psychiatry and Behavioral Science and Pediatrics at Emory, and the director of the Center for Maternal Substance Abuse at the Mother to Baby Georgia and the Emory Neurodevelopmental Exposure Clinic. I also want to note that I have no conflicts of interest. And this is just a little bit more about our center. If you are interested in learning more about it, you can log on to our website, and there's a great deal of information provided there. I also want to acknowledge those people who have supported our work, and these include the Centers for Disease Control and the National Institute of Alcohol Abuse and Alcoholism. I would also like to thank the people who have worked with us over the years, including the staff of the center here and the parents and children who have participated in all of our work. Today, I'm going to try to present information in terms of understanding the effects of prenatal alcohol exposure on behavior and learning. I want to then review the status of research on intervention and treatment to address those problems. And then I would like you to become familiar with some of the methods we use in intervention and treatment. Obviously, in the time we have, we can't explain everything, but we can certainly get an idea of the areas in which intervention and treatment has been effective. The first issue is, what are the effects on the child who's exposed to prenatal alcohol? And as you are probably all aware, there's a spectrum of effects of prenatal alcohol exposure. And this ranges all the way from fetal alcohol syndrome, which is the most severe outcome. And this includes meeting the criteria for having alcohol exposure, having alterations in the face, having growth retardation, and effects on cognition and behavior. You can also have a partial FAS, in which you have prenatal exposure and cognition and behavior and either facial features or growth. Some people have no physical features, and we consider that they have alcohol-related neurodevelopmental disorder, which is more a description than a diagnosis. In this case, the person has been exposed and they have effects on behavior or cognition. There is also a new condition, which is called neurodevelopmental disorder, prenatal alcohol exposure, or NDPAE, and this involves prenatal exposure to alcohol and behavior disorder. And this is the most recent way in which this is described, and this is recently described in the DSM-5, or the Diagnostics and Statistical Manual of the American Psychiatric Association. The reason for these problems, for the behavior and learning problems that we see, is damage to the central nervous system. And when we look into the brain of individuals who are alcohol affected, we find malformations and reductions in the volume of the gray and white matter which make up the brain. We also find thin or missing corpus callosum, which is a bundle of nerves which link the two hemispheres of the brain, and you see a picture of that on one side. We see alterations in brain activity. There are changes in the structure of the brain, and then the way in which the brain communicates with itself, with other parts of it, and in the way in which the brain acts when stimulated, change in this disorder. And we see alterations in what's called functional connectivity, which is the way in which the parts of the brain talk to each other. And of course, all of this is associated with reductions in overall brain volume. So there's not too much doubt at this point in time that the behavior and learning problems that we see as a result of alcohol effects are in fact the result of effects on the brain. This leads to a number of different problems as the child grows and develops. And we see impact on development of behavior across the whole range of areas. We see problems in physical health and in motor development. We see problems in development and cognitive behavior. We see problems with social behavior and in behavioral control. And finally, as the child gets into school and gets into adolescence, we see academic problems. And finally, as the person matures, we see problems with vocational activities. So the impact on the brain is having this comprehensive effect overall on the individual. The other thing that's important to recognize is this is a lifelong disability. We often identify individuals when they're very young, like this little boy who's shown at 2 years. But then when we look at this same person later on, which we've had an opportunity to do here in Atlanta, we see that as a teenager and as a man, they have the same kinds of problems, where they have the same effect of the alcohol, which manifests itself slightly differently over time. One of the other distinctions you can make is between primary disabilities and secondary disabilities. Primary disabilities are the things which are directly affected by alcohol, and secondary disabilities are those things which develop as an interaction between the primary disability and environmental factors, which lead to school failure, mental health problems, vocational failure, sometimes legal problems, and psychiatric diagnoses. One of the important issues in this field is to decide how these neurodevelopmental disorders manifest as academic and behavioral deficits. And we see that impairments in intellectual ability are observed, which as delays in development and as in cognitive deficits. These lead to academic and learning problems. And we see also problems with behavior, including attention problems, what's called externalizing behavior problems, impulsivity, sometimes self-injurious behavior. And I do want to bring to your attention that one common factor in these things is impairment in what we call arousal and in the regulation of arousal. This is something that's observed very early in life, during infancy, and if untreated, tends to be persistent over time, leading to a number of behavior and emotional difficulties. One of the important questions that then has come about is, if we see these kinds of problems, and we do very reliably, what should we do about it? And I'm going to talk for the rest of the time about intervention research and intervention. We began looking at the effects of alcohol on development early in the 1970s, when Dr. Jones and Dr. Smith first described this condition. But it was not until really about the year 2000 that treatment research began to be done in this area. That's 30 years. And so we only have treatment research for less than 20 years. Without having good evidence-based research on interventions and teaching methods, it's been very difficult to argue for targeted treatment of FASD. It makes it very difficult for the individual who is caring for the child or for the teacher who is working with the child to know what the appropriate way of interacting with this child is. I'm going to review now some of the interventions that have been tried and that which we know about, and which have been reviewed in a critical way so that we can feel comfortable in understanding the results. The first thing I'm going to mention is medications. One of the things that people are most anxious to know about in all kinds of behavioral disorders is medications. People often believe that medications are a quick fix for a problem, or that they are going to supply the missing element in the individual that's going to make things work when they haven't been working. This is an oversimplification of what medications do. The other problem in FAS is that to this point in time, there are no approved drugs that have been tested that prevent or reduce or specifically treat the symptoms of FASD. And I refer you to the review of the literature by Barron, Hockley, Fields, and Littleton, which was done in 2016, which looked specifically at this question. And I'm quoting them there when I'm saying there are no such drugs at this time. So what they say is currently there are no effective, clinically tested and approved pharmacotherapies that are specifically for the treatment of damage caused by alcohol during early development or as a later intervention as the child matures. So we don't have something that's specific for FAS in terms of medications. There are medications used frequently that treat symptoms that are associated with the condition, but those are simply addressed at specific symptoms or other conditions that appear to be associated with the disorder. Another thing that has recently gotten a lot of attention is nutrition. And there are two studies published fairly recently that found that children with FASD, when surveyed, had poor nutrition than what was recommended for children nationally. One of the problems with these studies is they really didn't use a control group, and so there are a number of questions about whether or not a similar group of children from similar environments might have had similar nutrition. But nevertheless, they did find that children with FASD had poor nutrition. People have been interested in this as an issue because it is certainly true that FASD is identified more frequently among people who have reduced circumstances or who are economically deprived, or in some countries who are in economically deprived situations like South Africa. And that raises the question of whether or not nutrition might be an intervention that would be useful in helping improve outcomes. I list here several studies which were done looking specifically at that question. One or two are those which I did and my colleague Dr. Cable did, working with Christina Chambers from the University of California at San Diego, in which we participated in a clinical trial that looked at the addition of prenatal vitamins and mineral supplements, as well as choline, in a Ukrainian sample, and followed children 6 months later to see whether they had better outcomes among those people who received nutritional supplements. This is called a randomized clinical trial, and it is allows you to have a better control of the variables that we're dealing with and to feel more comfortable in relying on the results. What I found in the paper that I published in 2015 was that those children who received micronutrients did slightly better than those children whose mothers used alcohol and who did not use the micronutrients. Both of the groups did not as well as children whose mothers didn't use alcohol. Choline in that group made no difference. Dr. Cable, who's my colleague, used a slightly different procedure that looked specifically at attention and memory in this group of children, and found that choline supplements had a protective effect on visual information processing. This has also been examined in a postnatal sample. Dr. Wozniak in Wisconsin in Minnesota, has looked at preschool children and provided them with choline supplements. The results of this were ambiguous. There's a slight suggestion for improvement of memory in young children. Another study was done looking at children 5 to 10 years old and used a randomized clinical trial, and they found no effect of choline on nerve behavior or other kinds of behavior. That's all there is for nutrition. Other kinds of programs include parent education programs, and there are several of those which have been done. In general, parents find these programs helpful, and that in many cases they have a positive effect on the child's behavior. So we find that a parent education program is frequently a very positive intervention method. Another way in which interventions have been done is to look specifically at ways to change the behavior of children. And this is typically done both through educating the parents about appropriate behavioral methods and also working directly with the child. And there's several studies, and I'm not going to go through each one of them here, but as you can see, there are studies that have looked at behavior and math, parental stress and child behavioral functioning, attentional control, self-regulation, more self-regulation, more self-regulation. Self-regulation is a very important outcome variable because many of the children who come to the attention clinically are children who have difficulties with self-regulation. And as you will note, most of these programs found that working directly with the child and focusing on these variables produced improvements in outcome. Most of these behavioral regulation methods incorporated typical behavior management training principles, what we call behavior mod, you may have heard of. And they're done in the context of dealing with how the neurodevelopmental damage associated with alcohol affects the child and using the behavior principle to support the child in overcoming those difficulties. We look at, for instance, how the deficit associated with PAE affects learning, and we do focus on supporting the child's learning. Or we look at how that has affected the child's ability to comply with parental instructions or the child's ability to self-regulate, and we try to provide support through these methods in improving outcome. And I'll say a little more about that later. A key component of this is learning how to teach the child to regulate their emotionality, to regulate their behavior. And we look at what's called arousal level. And we know that the individual has to be in what's called a calm, alert state to learn or to listen or to act appropriately. And then when they're too excited or they're asleep, they're not going to be able to control their own behavior. They're not going to be able to attend to learning. So one of the most important aspects of many of the programs that have been developed has been focusing on how to control this arousal level. So these interventions target impairments in self-regulation. Dr. Chasnoff's group, which is reviewed in Dr. Bertrand's paper published 2009, talks about his using the ALERT program in Chicago to work on self-regulation. And when we developed what's called the MILE program, which is teaches both behavior regulation and math skills, and in what our subsequently developed GO-FAR program, which takes the same methodology and works with adaptive function. In both cases, we spent a great deal of time working on self-regulation for the child to see whether we could improve outcome. We found that we did have a significant effect on behavior using those methods, and that the children showed significantly better self-regulation and learning as well. Oops. Another area which has been the focus of intervention studies is social communication and social skills. Many caregivers and teachers report that children who are alcohol affected are not really able to get along well socially, because for most part, not because they don't want to be friends, not because they don't like being with other children or people, but because they have difficulty learning the appropriate social skills and using them in a social setting. And there have been several good studies by Dr. O'Connor and her colleagues out of Los Angeles, and they developed what's called the Bruin Buddies Social Skills Training Program, and they have found positive outcomes using this methodology with school age and early teenage children. Another area that we have worked on is personal safety. One of the things that we see frequently in children with disabilities, and certainly children who show impulsivity, is that they are not very careful in situations where they should be, like crossing the street, for instance. As a result, we developed a couple of programs to look at fire safety, or teaching children fire safety and street safety. And I've listed the articles here. These were done using a virtual reality methodology, and you see the little animal who's teaching the course here. And children were able to play the computer game associated with this program, and they were able to learn the safety skills that we were trying to teach them and recall them a week later. And also they were able to demonstrate that they were able to, for instance, cross the street safely after using this program. Another approach was been done by Kimberly Kearns and her colleagues and Victoria. And here she's using a train your brain type game to address attention and working memory. And this is a computerized task that, as the child plays, teaches the child memory and attention skills. Another area that has been a focus of a lot of work is building academic skills. There are several articles listed here. There have been people who worked on reading and language and literacy, and you'll note the top 3 items have to do with that, although it is only the third one, Colleen Adams in South Africa, who really looked at a large group of children. The group that we work with here in Atlanta, we're looking specifically at math functioning. We chose math functioning because this seemed to be an area of specific deficit in alcohol-affected individuals, and we wanted to design a program that would be directed at that. We have found this to be quite effective and are continuing to provide training to parents and children, parents and teachers who are interested in knowing more about how to implement this program. Another important concern, and one which has been very poorly addressed, is the issue of adolescence. Most of the programs you note that I just reviewed are for school age or preschool children. There's been almost no work done with adolescents who are alcohol affected. One of the ones that has addressed that is, again, Mary O'Connor in Los Angeles, and she had a program focused on preventing adolescent substance abuse among preventing substance abuse among adolescents who were prenatally exposed. And it was called Project Step Up. And again, you can note that this article was published in 2016 in Alcoholism. The results were not as strong as they had hoped. They did not find a significant difference in children using substances after completing the program. So this is probably an area which needs a lot more research, and I'd like to see a lot more studies done in this area, adolescents, as well as in studies of much younger children. Most studies, as I mentioned, have been in school-age children, talking about 4-year-old through middle adolescence. There's been very little work done in babies and very young children and in older people. For those of you who'd like to know more about the studies that I just very briefly reviewed, I recommend that you look at these recent reviews on interventions for FASD. They include the article on medication development by Barron, Hockley, and Fields and Little, and then 2 papers by Christy Petrenko looking at behavioral interventions and family support, as well as an overview of the most recent publications in this area, which were reviewed in 2017. There's another paper that was done in 2015 that looked at a number of different papers overall. And finally, Young et al. Looked at the nutritional implications. So if you're interested in any of these areas specifically, I recommend that you look at some of these review papers. Now, to summarize, what kinds of recommendations does this research that has been done suggest to us are interested in working with alcohol-affected individuals. Excuse me. Well, generally speaking, if we look at an article by Jackie Bertrand, which was published in 2009, which summarized what had been found among a number of studies that were supported by the CDC. What generally appeared was that there's no point in trying to invent a brand new method that has never been done anywhere before. There are plenty of very good treatment methods available for children who have disabilities and who have some of the characteristics of FASD. And what the sensible interventionist is going to do is take these well thought through measures and adapt them to the special needs of the child with FASD. This is not to say that the person with FASD is just like every other child. They're not. But they do have special characteristics. But there are many things that can be adapted and adjusted to work with this particular group. Another important point is that the intervention and treatment that is developed needs to be able to be provided within existing networks. We can't say you can only do this in the woods of Canada 1 month a year. You have to have something that can be done in the school, in the clinician's office, where people can actually carry things out. The other thing that I find very relevant is that it's very important to involve the caregiver. Many times caregivers are concerned when we say that because they feel that that implies that they are responsible for the child's problems, and this is not the case. The reason that we need the caregiver involved is the parent is the one who is with the child most often, and they, if they have improved tools, can support behavioral change in a way that a professional is not able to do. So we often suggest that the parent be one of the focuses of the intervention, and that by supporting them and learning more about FASD and providing them with tools, that makes a great big difference in how the outcomes work. Another thing that we found to be very important was that explicit instruction is important. Many children who don't have problems of this kind seem to pick up what they need to know from the world at large, and they synthesize ways of doing things and are able to learn without having a lot of explicit instruction. When you have a child who has neurodevelopmental problems, it is not a good idea to let them learn things on their own. It is probably better to tell them what it is you need them to know, and to be very specific in teaching them skills using focused instruction. And we found that when we encouraged the child to learn how to do something right the first time and to really thoroughly learn it, that we had much less trouble over the long term. Now, after reviewing the literature, certain ideas occur to me. One is that the current knowledge, there are gaps in knowledge in how to treat FASD. And really, there are only about 35 studies that have ever been done that have adequate empirical basis. And some of those are very limited. So that leaves a great deal of knowledge and information still to be gained. We need, for instance, much larger clinical trials to validate some of the previous findings. Many of the studies I talked to you about are really only pilot studies done with a few people. And in order to know whether or not these things are really effective across the board and can be used in a number of different ways, we need to have more and larger studies. As I mentioned before, there are only a few studies of children 0 to 3. In fact, there are 3 of them, and one does not use a control group, so we're not really sure about that being a good study. That is to say, 2 studies of children that young, that is completely inadequate to allow us to provide appropriate advice. There is one intervention study in adolescents, which I told you about. This is really not an adequate sample to understand how to make recommendations to families. Medication studies are fragmentary and they have not demonstrated any reliable outcomes. That is not to say we should not do medication studies. We should, but we have to do them. We actually have to do them. They haven't been done yet. The nutrition studies in human samples do not demonstrate robust results, even though we found slight effects in the studies did in Ukraine. They're not what I would call robust. They're not a huge effect. They're just very small effects. So I think this perhaps is not a direction that is going to yield a lot. The things that have seemed to work best are behavioral interventions. And I think that's probably a path to go down, but again, there's much more work that needs to be done in that area. Now, there are some ways in which we can focus this. Christy Petrinko and her colleagues recently published an article looking at, well, they asked parents and professionals what they would like in a program for FASD. And these are the things they mentioned. First, services across the lifespan. FASD is a lifelong disability. It is not something that's solved by early intervention, by intervention in special education, by a 6-week course. It is a lifelong disability, and we have to direct our attention at providing services that are appropriate at each stage of life. Another very important thing that was raised by parents and professionals was the need for proactive services. Why wait until the secondary disability has developed? Why wait until the child is failing in school? If we know they're likely to begin failing in school, should we not intervene early to prevent that and to provide them with the support they need to achieve as much as they can? A third important element is individualized approach to intervention. Every child is different. This is particularly true when we look at children who are alcohol affected. Alcohol use during pregnancy is not the same for everyone. It doesn't have the same effect in everyone. Someone may drink early in pregnancy. They may drink throughout the whole pregnancy. So you're going to get very different effects over time. Therefore, the child has to be carefully evaluated, and a program has to be designed which is specific for that person and for that family and possibly for that school system, because each one is going to have to be an individual treatment plan. The parents also strongly recommend holistic and comprehensive services. It is really typically not sufficient to see only a psychiatrist, only a pediatrician, only a special educator, because as I pointed out earlier in this program, we see a wide range of deficits as a result of prenatal exposure, and different problems appear at different ages. Therefore, many times different professionals and different services are going to be needed. Therefore, we really need to think in terms of multidisciplinary services. Another very important element which was raised and which I agree with completely is coordination of services. We need to educate professionals about all this, and we need often to have case managers or people who can guide parents through the thicket of interventions and the thicket of medical problems and issues that will arise for the child. And someone who can help the families sort through the many different options and the many different issues that will be presented. This is an ongoing problem, this is a lifetime problem, and all of these kinds of issues are necessary. Just an aside, in 1996, the Institute of Medicine recommended FAS clinics to provide the kind of services that I've just described. Individuals can be referred there for diagnosis and recommendations, and then can be followed for treatment. Because of the many effects, they said a multidisciplinary team was best to make the diagnosis. And those people making the diagnosis would hopefully have specialized knowledge that would allow them to understand the effects of alcohol and discriminate those from other disorders. In addition, many children had social factors that needed to be addressed, as well as addressing the direct effects of the drugs. FAS centers can also be valuable as sites for evaluation of novel interventions and for training prevention and treatment specialists. For instance, here at my center, we every year train new psychologists, new psychiatrists, family medicine specialists, and pediatricians to be able to identify and treat children with alcohol effects. Finally, having a home can allow a family to receive consistent care and be followed over time so that they don't have to re-explain the issue over and over again to professionals who don't understand. In the future for interventions, we would like to improve access to care. We would like to continue to develop targeted behavioral interventions. I think it would be very good if we could develop targeted pharmaceutical interventions, and that's going to require more work. We need to know how to assess treatment effects. We need mechanisms for multi-site clinical trials. For instance, we need to have clinics cooperate with each other so that we can test outcomes more quickly. And probably develop standardized methods and protocols for evaluating treatments. In a more practical sense for the individual family, how do we address barriers to FASD care? Well, one of the things you can do is help increase the awareness of FASD. Webinars like this, but also many other ways, talking to people, discussing it, being open about the problem. We need to establish prevalence rates for FASD. How frequently does this actually occur? If you talk to many professionals, they believe this is a rare event, that you very rarely see children who are alcohol affected. Recently conducted epidemiological studies around different parts of the country suggest that it's much more common than we had previously thought. Another important thing is to document alcohol use in pregnancy. This is a responsibility for the people working with the pregnant woman and for the people working with the child once it's born. I see many, many charts in which other drugs are very well documented. People have been very careful to talk about marijuana and talk about opiates, but they have not talked about alcohol. And alcohol causes more problems than either marijuana or opiates for the child later on. Many of the systems that we have that deal with children who have developmental problems do not really think very much about FASD. And we need to think about how to make those systems work more efficiently for this group of children. We need to develop programs that can be integrated into existing systems, coordinate services, improve diagnostic capacity. It'd be a good idea to fund intervention evaluations and to disseminate evidence-based interventions. Let's talk about what's worked so far. Behavioral interventions have been more successful than other methods at this time. Parent interventions have been very helpful, and children respond to structured interventions focusing on behavioral management and skill development. So if we cook down everything I've said, this is what's left. And what is the implications of that? There are some barriers to care for children. Lack of FASD knowledge by professionals, caregivers, and the community. Delayed diagnosis. So children maybe don't get diagnosed when they're 2, and instead they're 7, and a lot of time has passed. There are problems in qualifying for services. The child may not fit into the neat categories that your particular state has, and they may not get services. Another problem is how available are the appropriate services. Sometimes we find that maintenance of service is a problem. We work with a child for a while and they get to the point where they go above a certain criteria or score, and then they don't qualify for services anymore. Another problem we've been seeing lately is sort of the skepticism about the risk of alcohol use in pregnancy. Documenting alcohol use in pregnancy. And there is a great deal of stigma associated with this disorder relative to some other disorders. And we have to work hard to prevent stigma from interfering with the care that children receive. So how can I apply this information to my child or the student? Here's some general rules based on what we know so far. There will be no medication that will fix all of the child behavior problems and the learning problems. Medications may help with specific problems in some cases. Secondly, intervention will probably be ongoing. While some children may have developmental problems that are easily treated and don't show themselves again, most children will need support over a long time. So you're in there for the long term. Behavior problems require specific attention. A child with a behavior problem is not going to have that behavior problem go away quickly, usually. And you have to specifically address the behavior problem to get a change. And this usually requires a lot of work both at home and at school. People sometimes really don't want to have to do that. And that can be a problem in working with people, is to get them to understand that, yes, we can do something to change this, but you're going to have to work a lot on it. The child will have different needs at different ages. So what a 3-year-old needs is not going to be the same as what a 12-year-old needs. And finally, one of the other things that is very true and is very difficult for parents is it can be difficult to find appropriate treatment resources, both financially and professionally. Early diagnosis, however, is important. Dealing with the child as an individual. Educating parents and interventionists about the disorder and its characteristics. Working on arousal levels, using behavior learning methods, and specific skill building. Let's talk about a specific problem. And this, I'm just taking this from our clinical experience. The child is not paying attention. Is medication the answer? Well, first, you ask these kinds of questions. Is this happening at home? Is it happening at school? Is it happening in both places? Does it happen at a particular time of day? Does this happen under certain circumstances? For instance, the child paid attention to anything? Or is it only when they're in a situation of having to learn math? Is it a new behavior? Did you not see it before and now you're seeing it? What has been tried previously? Did it work? Having asked these questions, then the professional thinks about ruling out intellectual problems, general intellectual disabilities, specific learning problems. We look for hearing and vision problems. We look for sleep disorders. Many of the children we see have sleep disorders. They're not sleeping. Their parents aren't sleeping. It's very hard to pay attention at school when you're not sleeping. We look for medical problems that might be affecting the child and interfering with attention. We look for language disorders that might make it difficult for the child to understand what's said to them. We look for a problem in arousal dysregulation that I mentioned before. We then look for family and social problems. I was talking to a child this week who was not having any problems until they had their caregiver had a severe accident and ended up disabled, and their other caregiver died. Then the child began having problems. That's probably not anything except the response to the social situation. And then are there problems at school? Is the child being bullied? So the if you have a good clinician, they will then look at these specific problems that might affect attention, and they will have solutions. So if it's intellectual disabilities, specific learning disabilities, language disorders, or school problems, they will assess them, they will intervene, they will provide a educational intervention, or they'll provide an intervention to the school to stop the bullying. If it appears to be a vision and hearing problem, a sleep disorder, or a medical problem, the treatment is medical evaluation and perhaps sleep evaluation and intervention. If it's a problem of arousal dysregulation or family social problems, then we're talking about a psychological intervention, behavior management, family therapy, and then parent coaching. If none of these work, then you seek medication, because then there probably is some kind of physiological problem. But you see how complicated this is. Another specific problem would be frequent meltdowns. And again, similar questions. Under what circumstances? Then you rule out problems with understanding requirements of. Sometimes children have meltdowns because they don't understand what's needed of them. Sometimes it's a problem with the way the discipline's being handled. Sometimes it's family dynamics. Sometimes the child does not have what we call a good response repertoire, which means they don't know how to handle something. And if we find that's the problem, if they have a problem with understanding the requirements, you try to identify the reason for that deficit. If they have a problem with discipline, you identify the most effective discipline methods for that family. If there's stressors in the home, you intervene in that area. If it's the child's response repertoire, we look for behavior management strategies and what we call metacognitive planning. One way we do this is through behavior regulation training, in which the child is taught how to control their emotional arousal. We do this through what we call FAR, focus and plan, act and reflect. And this is a strategy that supports increased self-regulation. Example, clean your room. So if you just say clean your room to a child who does not know what to do, they have a tendency to fall apart. The child goes into the room, they stand in the doorway confused by the mess. They get distracted and start playing with toys. The caregiver arrives, is frustrated, and yells at the child for not cleaning up. The child cries. The caregiver picks up the room or punishes the child. The child gets reinforced by not having to clean the room, and it goes around to the next time. You can do this differently. You can use FAR. You can say, it's time to clean your room. And you go to the room. The parent has a plan in mind. The parent asks the child to look at the room and the things that need to be cleaned up and implemented. They make a plan. They act on the plan. They review the results. The child receives positive reinforcement for appropriate behavior and learns how to clean their room next time. As this behavior becomes learned, the parent can gradually fade out and the child has learned a new skill. So that is the end of my talk, and I'm happy to answer questions or respond to comments or anything else that would be of interest.
All right, great. Thanks so much, Claire. We definitely have a lot of questions that have come in already. So I'll just jump right to the questions. One of them is, what are your thoughts on EEG neurofeedback as a treatment modality for the associated mood and behavioral symptoms of FAS?
All of my statements about interventions are based on research. I try not to give just my opinion. I do not believe that the research on this exists, and the research on this as regards other disorders like ADHD is not very strong, and it's a very expensive treatment.
All right. And we got a question about which form of choline supplement is advised?
I don't actually advise any of it. I don't think that it's demonstrated to have been effective.
Okay. And a question about is there a correlation between facial characteristics or stature and the severity of the cognitive and behavioral disabilities?
Yes, generally speaking. Probably not one-to-one in every case, but there's certainly overall is a relationship.
Let's see. All right. Thank you. And let's see, another question here about mentioning the lack of pharmaceutical therapies for FASD. The person is asking, as a researcher in the field, what kinds of mechanisms are clinicians hoping to see? And are there specific neuroproteins associated with deficits in FASD patients that are validated druggable targets?
That's a wonderful question, and that's probably the direction in which research is going to go. This has been not well examined as yet. There are animal models being evaluated at this point in time in this area. I refer you to Dr. Dan Savage's center in New Mexico, because they are directly looking at some of the precursors and thinking about different type of medication types in his shop. So I think that would be a good place to go. And then there are some other substances that people are talking about, but they really haven't validated it as yet.
All right, great, thank you. And another person asks, can you provide an example of what a targeted or appropriate behavioral intervention might look like?
Well, as I was trying to do that with the last couple, the clean your room example, excuse me, but many of the children we see, the complaint is that they are non-compliant, or they have a problem with falling apart, melting down. And we have found that by providing them with this metacognitive strategy, this method for dealing with a new problem when it arises, that we have been able to cut down on the number of periods of upsetted behavior. So you can certainly target things like how long you get them to work on their homework. You can target getting them to dress themselves. You can target them to clearing the table. I mean, anything you want to. It's just a matter of setting up a structure.
All right, great, thank you. And another question that came in, is there a known link between the time of alcohol consumption during pregnancy and development of FAS? Like, is there an increased risk with consumption in certain trimesters?
Well, that's an absolutely wonderful question, and one that we have a very difficult time answering. There are, again, animal models, because we can't do any real research with humans with this, basically because there's no way to control the exposure in humans. We have had several studies done very early on where it was suggested to women who came in to register for care that they stop drinking, and they did, and they had significantly more positive outcomes for those children than for those who continued to drink. So that even though they've been exposed during the first part of the pregnancy, it's evident that the facial features, and this is both from what we know about anatomy and development, and also from animal models, it's evident the facial features are being caused, if you will, by exposure during the early part of pregnancy, because that's when those features develop, and probably growth is affected throughout, but there's a big period of growth development in the third trimester. As far as we can tell, the effect on the brain is ongoing throughout the pregnancy, probably has slightly different effects. But the only way to look at this is to go back and look at the animal studies, and to the degree the animal studies are analogous with the human, And they're not always, because human beings are different than animals.
All right, great, thank you. And we are getting just about to 3 o'clock, but we do have several more questions that we're not going to be able to get to all of them. But Claire, do you have a few minutes to go over some additional questions?
Sure, I'll be happy to.
Okay, so we'll just try to get a few other questions in there, and some of the ones we don't get to, I can send to the presenter later. So we have a question about, are there any interventions specifically for adults that you can talk about?
There isn't even any research on adults with FAS to speak of. I mean, it's just incredibly sparse. That no one has even addressed these issues in any systematic way. So no, it's the answer. I wish there were. The only group that I know that has worked with adults with FAS in a sort of systematic way is Therese Grant's PCAP group in Seattle, and they've been working with women at risk, and they found that they have quite positive outcomes working with pregnant women with FAS. But in terms of some of the other aspects of this, it really hasn't been done yet.
All right, thank you. And we have a question asking about, do you think we need community-based FASD-specific intervention services, and if so, what would those look like?
Well, I guess it depends how it's done. I mean, we've thought about this a lot, and I don't know that you'd want to set up an FASD classroom. Well, I don't know if you get enough kids. You might be able to have a group therapy of some sort, but I think that it would be probably better to have it as a part of the educational process for professionals, so that they would be able to have techniques that they could take out of their repertoire and apply when the child came into their care. So yeah, it needs to be community-based, but I'm not sure. I don't know that we'd want a school for kids with FAS or anything like that. But I do think that it's important to have FAS clinics or FAS centers, so that people who know about it can communicate with other people.
Okay, great, thank you. And we have a question from a parent asking, as a parent, is there a place to go to for more information, for direction of where to be guided for more information about the FAR intervention?
Yes.
About?
If you will go on my website, which is Maternal Substance Abuse and Child Development, it talks about that, and it also gives you a place where you can email us and we'll send you information.
All right, great. And somebody was asking about how do you help a child at home and away from home with their social skills?
Well, it appears from what Mary O'Connor and her group have done that you can teach social skills. Typically, social skills are taught in groups because you're talking about social. And so setting up a group of kids who have a specific curriculum to learn and learn how to interact with other children. And again, a lot of social skill development is sort of this intuition. You go into a group and you figure it out because you can pick up clues. And we have to assume the alcohol-affected child is not able to pick up the social cues very well. So what Mary O'Connor's group did was teach them the cues, teach them how to integrate with other kids, teach them how to offer appropriate conversational bids and so on, so that they began to learn the right way to do it. So explicitly teaching them the way to interact with other kids and then letting them practice it in groups has proved to be effective.
All right, great, thank you. And just a couple more questions before we close. Somebody's asking about, have any programs been created for personal safety, like stranger danger type issues, and for sexual behavior issues?
I am not aware of that in specific FAS, although certainly that is incredibly important and probably should be a real focus for intervention. I think that may be occurring in some clinical settings, but I haven't seen published articles about that.
Okay, thank you. Sorry, you have more?
No, it's such an important issue.
Okay, great, thank you. And do you have a sense of roughly what percentage of kids with FASD might also have an ADHD, and the percentage that are treated with ADHD medication effectively? And also, what percentage of kids are estimated to not yet be diagnosed with an FASD?
Well, I don't know what the percentage of kids are diagnosed with an FASD, so it's hard to go back from that. The latest epidemiology stuff I've seen, which isn't published yet, is looking like 2% of kids in the first grade classrooms can be called FASD, which is a huge number. They're not severe, most of them, but they are affected. But so I would suspect that there is a huge number of undiagnosed kids, and some of them might not need to be diagnosed. Some might. It depends on how severe these things are. As far as ADHD goes, I've been doing this for 20 years with ADHD, more than that. And we did a paper in 1996, I think, in which we compared ADHD to FASD. Both of them met criteria in certain ways for ADHD, but when we looked at it more carefully, we found that they separated out to two distinct groups, and they weren't really quite the same. And I think a lot of kids get diagnosed who are FASD, get diagnosed with ADHD, and they don't really have it, and they get medicated, and it's not very effective. So I think that we have a clinic, so we see the people for whom it was not effective. So I may be biased in my perceptions of that, but it appears to me that a lot of kids are being misdiagnosed with ADHD when they really have FASD, and they need to be treated with something else. That is not to say that there could not be overlap. There certainly can be, and probably is. And some people do report significant effects, but I've never seen any real honest to God data saying this is what the percentages are.
All right, great, thank you. Well, that's all the questions that we've got that we have time for. And Claire, was there anything else that you would like to add in closing?
Just thank you for listening, and I appreciate everybody's attention, and I hope that it was of value to people.
All right, great, thanks so much. So just a reminder again that a video recording of this webinar will be available on the NOFAS website at nofas.org. Also, please take a moment to fill out the brief survey that will pop up or be sent to you. Also, we'd, again, just love your support of NOFAS. You can go on the NOFAS website at nofas.org to view other webinars, and again, to sign up for our weekly email newsletter, the NOFAS Weekly Roundup. Please like us on Facebook, follow us on Twitter and Instagram and our YouTube account. So again, thank you, everybody.